been a longly decided topic, but we found this coincidentally that the patient is already there on a BIVAD, and let's discuss something about the BIVAD. As the terminology, it's self-explanatory. I hope I'm audible and the slides are visible to everyone.
The slides is there. Have you started to move it? Because we are
No,
only
no,
seeing
not
the
yet.
first slide.
Not yet.
Okay.
This is the first
Fair
slide.
enough.
Okay. So as the BIVAD means, it's a biventricular assist device. It's a self-explanatory terminology. We'll just take a quick overview of the perioperative care. We won't go into the details, but yeah, definitely what what is expected out of this is which patients will be subjected to ECMO, which patients will go for LVAD or RVAD, and which patients will go for BIVAD. That's the decision making. But majority of the times, the decision been made by the cardiologist and the surgeon and the anesthetist, and then eventually patient comes to the ICU. Many a time it happens that uh, patient is admitted in ER or in the ICU for a couple of days, and then we try to optimize medically. And at certain point of time, we notice that this is not going anywhere, and the patient is getting acidotic, needing more of oxygen or any other intervention. Might be we put intra-aortic balloon pump, which is insufficient, and then we look forward to manage these kinds of patient, and then uh, we 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 need to decide what will be the best possible MCS, that is mechanical circulatory support system for that particular patient. So once we finish this discussion, I think that is the most important part we should be able to understand is what patient will require which MCS, one. And the second part is once the patient is shifted back to the ICU, we should be in a good position to understand the mechanics, the mechanism, and the post-operative care of such patients. Because it's very important to understand the mechanism of this BIVAD or ECMO per se, all the MCS, just to make sure that all other organs, including brain, lungs, liver, kidney, remain in a good shape, good zone, and so that we have a good candidate for the heart transplant. So if you broadly classify the uh, mechanical circulatory support devices. They are mainly ECMO and VADs. Sorry for the spelling mistake. ECMO, they can be central ECMOs or peripheral ECMOs as per the uh, insertion site. In emergency or what we see in the ER or ICU, we put peripheral fem percutaneous ECMOs. On the other hand, a ventricular assist device, they can be put again surgically in the operation theater or again in the percutaneous fashion. So if it is for there to assist left ventricle, it will be LVAD, left ventricular assist device. Similarly, for the right side, it will be RVAD. Impella is the percutaneous device which uh, partially or nowadays completely assist the left ventricle. It's a percutaneous device, but mean for the use for the shorter duration, maybe for hours or during the percutaneous coronary intervention. And similarly, for the right side, now we have a Protect DO device, which works as a right ventricular assist device. So what we'll discuss, these are the three cases what we have done in this hospital. We will not disclose the final plan for these cases. We will just go through these three cases, and at the end of the our discussion, we will come back to these cases and we will discuss the plan what we will do. Because as we know, we have the choices of multiple MCS nowadays. So this is the first case, 82 years old male patient. He's with coronary artery disease, left main coronary artery disease, and he was posted for angioplasty. Angioplasty was done uneventful and immediately post-operative. He had arrhythmias, hypotension. He went on high inotropic vasopressor support, intubated, intra-aortic balloon pump was put. The screen echo after IBP showed LV stunning and ejection fraction of hardly 10%. And then the question arises, in spite of angioplasty and all the possible, best possible uh, medical management, still we are stuck with the cardiogenic shock. The second case is a 42 years male patient. He's a known case of DCM referred from other hospital with acute and chronic picture. We managed him with diuresis and inodilator for 2 days. But after 2 days, eventually the urine output uh, kept dropping. The oxygen requirement went on, and there was need of NIV SOS intubation. So it was a mm, impending cardiogenic shock situation. So what will we do in this scenario? The third case is a 72-year-old male, known case of ischemic heart disease since 20, 30 years. He's been put on AICD. EF since 20 years is 10 to 15%, but now came with the intractable arrhythmias. And in spite of best possible antiarrhythmic medical therapy, he's still throwing arrhythmias and in LV failure. So this is the third case. So we'll come back to these cases once we finish with our discussion. So here we will mainly discuss about the ventricular assist device. We all are now well versed with the ECMO, which is the extracorporeal membrane oxygenator. Uh, these ventricular assist device, as like ECMO, they are the centrifugal pump. What we use here is a Centrimag is the name of the company device. So the most important thing which we need to understand in VAD is this line. This is pre-load dependent and after-load sensitive. So whatever adjustments we do in the rotations per minute, they will not be reflected in the cardiac output in the sense that it should have an adequate preload and it should have an adequate afterload, not too high, not too low. So uh, if it is a left ventricular assist device, LVAD, so the preload for LVAD will be from right ventricle, and the afterload for LVAD will be patient's native SVR, systemic vascular resistance. So for the LVAD, we should have a good cardiac output from the right side. Maybe the native right ventricle should be good enough to give cardiac output to the left side, or the patient might be of RVAD. And the afterload, the SVR, should be adequate so that this centrifugal pump can generate adequate cardiac output against that SVR. Similarly, for the RVAD, the preload will be venous return. The venous return from the SVC and the IVC, that will be preload for the RVAD. And the afterload for the RVAD will be definitely the uh, the PVR and PA pressure. So as we know, we can adjust the revolutions per minute to get a desired cardiac output. So in this Centrimag machine, the RPM can be from 0 to 5,000. That is the maximum RPM you can have. Uh, and the cardiac output is majority clinically achievable cardiac output is 7 liters per minute. So whenever the decision is taken that this patient will be going, this say supposedly this patient is there in the ICU on the maximum best possible medical therapy, and the decision has been made to put the patient on BIVAD. So what all preparation we need to do from our end is the consent, reservation of the blood products. Definitely, as this patient must be having central venous pressure monitoring, urine output monitoring, arterial line. Maybe patient are on NIV or mostly on a ventilator support. And these are per se uh, very critical patient, and uh, there are high chances that patient may go into bradyarrhythmias or ventricular fibrillation, tachycardia any given point because of the ventricles are so dilated that it's difficult to regain the sinus rhythm. So these are the critical patients, and I think once the decision is made to shift the patient to operation theater, we should be more cautious while shifting these patients. Once this is how a Centrimax screen looks like. On the left hand side, if you see uh, on the left top, we have written a LVAD sticker. On the right top, there is a RVAD sticker. And also, this just for our easy understanding, we have done a color difference also. So the LVAD is shown in the a red color, a red background, and the RVAD is shown in the blue background, considering the left side and the right side of the heart. Uh, Down there, we can have the cardiac output, which is ranging from 0 to 10 on both the sides, and we can see a reasonably stable two lines. The red line depicts the LVAD left-sided output, and the blue side depicts the right-sided output. If we see the numbers, reasonably good numbers, and the RVAD, this is what the ideal flows look like. The RVAD and LVAD flows are same. It's always better to have slightly higher left-sided flows than right-sided flows. The obvious reason is that there will be otherwise a pulmonary congestion if the right-sided flows are more than left side. This is how the both the pump look. Uh, this is the picture taken from the current patient, and the very obvious thing which you will notice is that one is brighter red and brighter red, and other one is dark red. So again, the obvious thing is the one which is at the bottom, it is a LVAD, and the one which is at the top is RVAD. This is the picture of this similar patient. This is how the monitor will look like. This is for the understanding who haven't seen BIVAD or LVAD patients, just for their understanding. Here, uh, the rhythm per se doesn't play a major role in BIVAD patient because anyway we are bypassing the both the ventricles. But yes, if it is univentricular support system, you should have a sinus rhythm because, for example, if it is the left ventricle assist device, the preload, as we know, is from the right ventricle. So to have a good preload for the left side, you should have a good ejections from the right side so that there will be adequate cardiac output generation from the LVAD. But as this patient is considered, this patient is on biventricular support system. We are not having any pulsatility in the arterial tracing with a good map. Okay. So again, if there is a pulsatility, it is acceptable. Uh, but other, what does it mean that you can still go up on the elevator flows? Uh, Similarly, you will never get a pulse oximetry trace when the patient is on uh, LVAD or for that matter ECMO unless and until the left ventricle ejecting. This is a common picture of a screen and the main console. So there are two consoles, one operating LVAD and another operating RVAD. And similarly, the same screen is on the background. This is how we receive the patient in the ICU, there will be multiple tubings. So on the left side of the screen, you can see the left ventricle cannula and aortic cannula. On the right side of the screen, you can see the right atrial cannula and pulmonary arterial cannula. In between these two, or rather these four cannulas, what is there in the center is the drains, the pericardial drains and pleural drains. So this is how a patient will be seen once we receive patient in the ICU. So whenever we receive this patient in the ICU, what are the checklists that we need to do? So as we discussed here, again, examine the cannula site, the insertion site, all the cannula insertion site. Make sure there is no kinking, there is no bleeding, there is no hematoma around the cannula. Next thing is cannula identification. As we know, there is obvious visible difference when it comes to the BIVAD cannulas. The left-sided cannula, because of the oxygenation which is there from the lungs, they will be bright red. As you can see from the left side cannulas, they are bright red in color. The right side RVAD cannulas, they are a dark red in color. So anytime you see a patient, the obvious thing which you should notice, the first and foremost is the color difference between the two sets of cannula. Always see for the mechanical compression or any slightest of the kink. Many times patient who are awake, uh, patient in sitting position, or the sometimes patient are made to sit edge of the bed, patient are made to sit in the chair. Always look for the mechanical compression or the kink which is happening to the cannulas. Obviously, it will be reflected on the flow fluctuations, but this is one of the checklists you should do whenever you receive a patient or whenever you take handover of the patient. Again, the power connections, because all these consoles, they are uh, battery powered. They during the transport, they will sustain battery backup for I suppose 3 to 4 hours. And but once the patient in the ICU, make sure that the uh, power is connected to the console. Always look for the RPM, LPM values as we discussed for the right ventricle, left ventricle, and flow fluctuations in this uh, on the screen. So as we see here, the flows are relatively constant. So just one with the one look, we get to know here is that the right and left sided flows are almost equal. We can we would like to have maybe 200 to 400 ml more on the left side as compared to right side, but they are relatively stable flows. So once this checklist is in relation with the BIVAD machine and the cannulas. What next is the monitor, which we have already seen. Mean arterial pressure, CVP, patient's urine output, and ABGs as per the need. So these are the things which we will be seeing once the patient is in the ICU. Many a times, what happens is initially we start the patient on LVAD and we try to come off pump in the operation theater, thinking that his RV might support. But if it is not the case, we put the patient off BiVAD. Many, few times, not many times, few times it happened that for some reason the oxygenation get hampered. So we need to put the oxygenator in the ongoing BiVAD circuit. So preferably, always the oxygenator put on the right ventricular assist device. For the current patient, we also had to put oxygenator for a couple of days. Once the native lungs started functioning well, the pulmonary congestion was taken out with the good urine output. We removed the oxygenator after 2 days. But also look for the oxygenator whenever we are receiving a patient for VIVAD. Daily checkup with anticoagulation. So the protocol for the BiVAD are similar. We keep the ACT between 160 to 200 uh, and make sure that if the patient needs heparin, we start as per the protocol. Also, we should be equipped with the bedside uh, echocardiography if needed, transesophageal echocardiography because any change in the fluctuation of the flows, uh, we have to do a examination of the patient, cannulas, kinking, mechanical compression. Along with that, we also need to see the condition of the heart, meaning that how the ventricles are filled, where is the interventricular septum, is there any collection around the heart which is compressing the cannulas. So a bedside echocardiography or early availability of the echocardiography is another necessity whenever there is a patient of BiVAD. And apart from this, a regular routine ICU checklist on a daily basis. How is the neurological status? How is his muscle power? How is his breathing dynamics? Are we? It's always advisable to extubate the patient once the initial stability is achieved, so that we can start with the physiotherapy and start with the enteric feedings. So all these things are evaluated on daily basis, or rather more frequently than the other patient, and we make sure that all other organs are in good shape. So there will be, as this is a mechanical circulatory support system, there will be always some problems. There will be always some technical difficulties we will be seeing through the course of the ICU stay. So we will be always having these problems with flow fluctuations. This is the most common troubleshooting what one need to do when the patient is in the ICU. Obviously, this is a surgical implantation of a BiVAD, so we need to look for the drains, and in turn, we need to have a good maps and a reasonable CVP so that all the organs are preserved well. So this is a small slide. There are one, two, three, four common uh, scenarios where we will be having trouble. So the first scenario uh, will be with the right ventricle assist device. The second is LVAD, third is MAP, fourth column is for the CVP. So the first scenario is like there are fluctuations in both the VADs, the MAPs are low, and the CVP is also low. So this is mostly seen very early post-operatively. I think we can unmute ourselves and uh, put your opinion, whoever wants to, because this is the last slide, and then we'll go back to the three cases which we have discussed before. So the first scenario, right ventricular, left ventricular flow fluctuations, mean arterial pressure is also low and CVP also low. What we will do?
Hypovolemic.
This?
Hypovolemic could be the cause. So we
Yes,
can try with the fluids.
absolutely. Yeah. So we will temporarily go down with the flows both on RVAD, LVAD. We will give the fluid. Okay. So once we build up the map, we will increase RVAD, we will increase LVAD, and automatically it will correct the mean arterial pressure. So the first scenario is of the hypovolemia. Hypovolemia, initially, these all these mechanical circulars, they need lot of volume. They need a good preload. So this is a simple, most commonly seen problem when we have a BIVAD. The next thing is there are flow fluctuation in both the VADs. Mean
Mhm.
arterial pressures are low, but the CVP is high.
Kink.
Well, in the LVAD.
One possibility.
Mm. So
Whether is LV function related or
because
So
here CVP is high and
yes,
others
one
are low, so
first,
kinking of the
very true. The first differential will be kink on the right side. Okay. So that's why the CVP is high, and eventually it is leading to both the VAD flow fluctuation. Okay. Another differential is
Pulmonary
tamponade.
hyper high
The
pulmonary
another
pressures.
high pulmonary pressures, high PA pressure. Very unlikely. Okay. Because in that matter, uh, once you decompress the left side,
Mhm.
it's very unlikely to get high pulmonary pressures. So this is a simple case of a tamponade where you get lot of flow fluctuations, low MAP and high CVP. Okay. The third scenario, the right-sided flows are good. There are no flow fluctuations on the right side. There are
Hmm.
flow fluctuations on the left side. The, the, the mean arterial pressures are low and the CVP is normal. So basically, the left side is compromised. The right side is good.
Increased afterload.
So
Yes, increase afterload to a certain extent true. So जैसे
flow. Hmm.
हाँ, so left side cannula king. Okay,
Then
so
can
there might be mechanical problem with the left-sided cannulas. Second, whenever there is a suboptimal anticoagulation, we expect that there can be a thrombus which has stuck to the LV cannula, and that's why there is no adequate left ventricular cardiac output through the LVAD.
Hmm.
So the last scenario, so there are no flow fluctuations in both the VAD. The maps are low and CVP is low normal. So
flow
imagine a patient who is a POD 8 with this scenario.
sepsis could be the
So
possibility.
this can be one, hypovolemia. More importantly, this can be low SVR status
Hmm.
and this can be early sepsis. Okay. So we go back to three cases we discussed. There are 26 candidates, or I think everyone can put their opinion here. 25 now. What would be the ideal MCS here? So
We
this
can
is a near arrest situation. Okay, the patient is in the cath lab. The procedure has been done. The coronary flow is restored, but there is a temporary myocardial stunning. So to me, the best MCS for this situation will be immediate percutaneous fem-fem ECMO to stabilize the patient. As the cardiologist has achieved the coronary flow with support for couple of days, the heart function will be normalized and we can wean him off ECMO.
So, Dr. Rohit, this
Bolo na.
condition with or without IABP, because you
This
are
is with
LV
IBP.
resistant with
Yes,
IBP, right?
IBP is
Because
been
you are
put. I
LV
haven't.
resistant.
Yes, IBP is put already. डाला नहीं है मैंने. This
Uh, uh, mhm.
immediate post-op procedure continuation of high supports IBP ventilator. Okay, we go to the next case. क्यों नहीं जा रहा है? This is a case of DCM who is not responding to our medical management.
So this patient is candidate for if 42-year-old transplant. So by VAD we can consider
He's
here.
been registered for transplant.
Yeah. So
So this for him
we'll do not
as we
miss.
have a time, okay, we are not still in a position where the supports are very high. He's still on diuresis and milrinone still without any inotropic vasopressor support. Uh, we can buy some time. We can get the patient to operation theater and put patient on BiVAD. See if he needs oxygenator or we can get away without oxygenator. So this patient was put on a BiVAD and then transplanted. This is the third case. Long-standing ischemic heart disease patient.
Simply map or
And he's also been
R.
and he's also been evaluated for transplant
But
and
we
listed.
for what?
So I think Rohit, this was our these are all our true cases, right? We've gone
Yes,
through all of them. Yeah, yeah.
yes, yes.
I understand who this patient is. Our
Yeah.
paper is coming out on this patient. Anyways, let's go ahead.
Okay. So these patients we had put temporary LVAD and then we had listed him suprachal and we did a heart transplant of this patient. So the bottom line of these all these MCS is to keep patient in a zone so that patient receives a heart and patient remains in a good zone in terms of other systems are concerned. So thank you, Arindam sir. Thank you, Dr. Mehul. Uh, over to you, Dr. Arindam.
I think Dr. Tala, first I will take your comment and then I will go to Dr. Pandit has also joined. So if you may please give your valuable opinion. Tala, I have to unmute.
Yes, sir. So, Rohit, thank you. Good, very crisp and precise presentation. I like that table at the end with the four clinical scenarios. I'm going back to your three case examples that you gave. The first case where there is that 82-year-old post left main LAD plasty in cardiogenic shock on balloon pump ventilator in the cath lab, very high supports. Could we not have also considered, now just strictly academically speaking, an Impella 5.0? Patient is in the cath lab on the table with an arterial sheath. If we have a Impella 5.0, mind you, I'm not talking about the Impella CP, I'm talking about the Impella 5.0. This could have been the perfect solution for his
Very,
short
uh,
short-term
yes,
problem. Yeah.
yes, very true. Uh, to begin with, uh, we could have initially put Impel and perform the PCI,
Mm.
but that was not, I think that was not what they expected. They electively put IBP and perform the PCI. But definitely, yes, Impella 5.0 will be definitely giving a good cardiac output. And if it is available, readily available, that was the go-to device for this patient.
Yes. So for logistical reasons, in this case, ECMO was selected, and anyways, patient did well even on the ECMO. So that's fine. But academically speaking, yes, Impella would also have been a good option. Now, Dr. Rohit nicely took us over, trying to differentiate between which devices for which kind of patient. I think, thinking one step back, taking a step back and looking at the big picture, it's also very important to uh, identify shock early and to initiate our shock pathways as early as possible. I think most of the current consensus statements and guidelines keep harping on this, because most of the time shock is, by the time we realize patient is in cardiogenic shock, there have been already 3 hours of no urine output, and the liver enzymes are on their way up. So that is probably not, the time where we want to institute our MCS. So identification. So there are different ways you can identify and prognosticate and stage the cardiogenic shock. For all our viewers and listeners today, there is a good consensus document from ISHLT, which talks about shock staging and prognostication. The latest ISHLT document also incorporates the newer classification for cardiogenic shock, which is the SKY staging and classification. The SKY staging and classification is sort of the newer thing for cardiogenic shock, which was introduced in 2019, 2020, and now over the last 5 years has been validated. So everywhere on an international stage, everyone is now talking about SKY staging, as opposed to what we used to discuss before is intermax profile. So SKY staging and in early initiation. Another point that I would like to make here is um, early use of Swan-Ganz catheter. This has also been extensively studied in ICU settings of how underutilized they are in cardiogenic shock settings, the Swan-Ganz catheter, and how they can drastically improve our ability to diagnose shock earlier, as well as institute the correct form of mechanical circulatory support.
True, true, Dr. Tala. You are mute.
Yeah, I think Pandit sir is here. So
Hi, Tala. Hi, everyone.
Hello, sir.
So, Rohit, very nice. I joined around 7 minutes late, but I could listen to most of your presentation. So, as Tala repeated, as Tala said, I'm just going to repeat the same thing, that the presentation was very nice and crisp. You had good case scenarios. Now, the most important thing which Tala, I think, mentioned is the recognition of shock. And that's where very often a lot of people find it difficult, because hypotension, by the time hypotension sets in or urine output drops down, you're too late. So you need to start recognizing at molecular shock. Lactate is a very good way of looking at that, and quite often we look into that because the ABGs give you a lactate very quickly. And it's important to start acting as soon as the lactate touches 3 or above. You can't be waiting for it to go to 5 or 7. As soon as it touches 3 and above, you need to start working on that. Pulmonary artery catheters, absolutely very good if you have a problem to actually to understand whether there's a mixed shock or it's a cardiogenic shock. But again, we underutilize them, and the cardiac output catheters or the automated ones, which actually would give you HCVO2 as well as cardiac output, are not been put nowadays. So we need to go back to, at least in the pure cardiogenic shock patient, we need to go back to understanding of how to interpret pulmonary artery catheters. And there's a whole generation of people right now in ICU in cardiology who have never even used the pulmonary artery catheter, and they would not be even able to understand the waveforms differently. So there is no harm in putting a pulmonary artery catheter. Quite often the pulmonary artery catheter is put in for these surgeries, but the only figure which is looked at is the PA diastolic. People have forgotten how to wedge it. People have forgotten where to wedge it, and it's a big problem. So I think let's start doing that. Let's Arindam, let's bring back some pulmonary artery catheter into our clinical understanding. Let's take a class on pulmonary artery catheter, how to use it, and start practically using it, because many patients have a pulmonary artery catheter floated in, but the utility of that is very minimal.
Fair enough, sir. Will do.
Okay, great. Thanks.
As an extension to what Pandit sir is saying, there's actually very good data which states that there's difference in outcomes based on how much information you derive from your PA catheter. If you're just looking, as sir said, only at the CVP and the PA pressures, or if you're looking at the detailed parameters, the cardiac output, the SCVO2, you do the extra bit and calculate the SPR and PVR. So there's actually data which says that if you look at all of these numbers, these extra numbers, your outcomes are better as compared to just the basic numbers. So definitely, I think we have lots of room to that standpoint.
Yes, Dr. Arindam, sir.
I think Arindam sir is a little busy, so I'm going to
No. Sorry, call आ गया तो sorry about that. Now, Tala, I think you were also talking about impeller, though we will have a separate class on the impeller, right? And so my one question is to you on to give a brief sort of idea that how impeller could have worked better in that situation, and also to Dr. Pandit if he's still there, that why not in certain cases we think of a VAV ECMO instead of sort of BiVAD, because maybe the BiVAD could be a sort of a process where exit without a transplantation and others would be difficult. So why not a little lesser process of a VAV? I think Dr. Pandit, you take the first question, and then Tala can come back on the impeller itself.
I think there is no harm in considering VAV. If you have, especially if you, or even just a VA, especially if you have a hepatic congestion which is very bad, in those patients you will be able to empty the RV completely, beg your pardon, RV completely, and thereby help the preload reduction on the left ventricle. The challenge here is to actually understand where you want to bridge it with the VAV, and that's where it becomes difficult at times. Once you start returning some flow back into the right side, it becomes a little difficult for the right side to be emptying out completely, and that's where the concern starts coming in. Whereas a VA ECMO, the biggest problem in the VA ECMO as opposed to a LVAD or a BiVAD is that in VA ECMO, even if you put in the auxiliary conduit and place the catheter at the SVC, so that the subclavian artery junction, you are still not as good as in the aortic route, which is actually where you would put it onto the LV. So that's the big challenge that you have to see. What is the bad thing? The RV is the bad problem or the LV is the bad problem in your case? And if RV is the problem, I think if you can empty the RV by putting in 2 drainage cannulas completely, and then going and putting the arterial cannula in the subclavian artery will help you. If RV and LV both are very bad, then the challenge is very difficult. So the answer may not be very easy at that time.
Tala, your opinion.
Yes, so I completely agree. I think if it's a severe biventricular problem, then I don't think VA ECMO is the choice. I think sir perfectly summarized it. If the LV is also struggling, I think you better start thinking about BIVAD, because VA ECMO, as we know, can cause LV distension as well, which is not good for the left ventricle. You are not only giving the LV a chance to, so say if it's an acute cardiogenic shock with severe biventricular dysfunction, and if you put them on VA ECMO alone, you're technically not giving the left ventricle the best chance to recover, because the best chance for the LV to recover is from unloading the LV. I'm going to extend the same discussion for the impeller case as well. Now, the focus in even in acute MI shock is acute myocardial infarction related cardiogenic shock is not on door to balloon, it's from door to unloading. Door to unloading the left ventricle. It's not from door to putting in your balloon or reperfusing. Once you have already, so this is for not for all acute MIs, this is for acute MI already in cardiogenic shock. The guidelines, or not the guidelines, I would say there's a big shift in data which says that once you start unloading the left ventricle with using a percutaneous LVAD like an impeller, your infarct size and your patient outcomes are much better as compared to just doing the conventional strategy. So
let me interrupt you, because this is a big shift for the critical care and emergency physicians. So you are saying MI with cardiogenic shock. So the first step is to have a percutaneous LVAD, offload, reduce the overall stress on the LV, and then go for the PTCI.
correct.
Is
Yes, sir.
that
So there have been animal studies which have now been replicated into human studies, and this is well validated across multiple centers in US and in Japan. Now there is a big group working on it called as the Cardiogenic Shock Working Group, CSWG, and with their sort of one of the main centers being in Detroit. But this is where the field of cardiogenic shock is heading. So it's important to be with the flow.
Now, if I'm not mistaken, Tala, a lot of a couple of Mumbai hospitals have also started adopting this strategy, including I'm reasonably sure you have considered in certain situations.
No, so sir, that is different. Doing a what people are doing, and what there are many cases all across the country. They are different. For impeller assisted PCIs, these are planned interventions on patients with chronic LV systolic
No,
dysfunction.
I'm reasonably talking about impeller assisted PCI. There had been certain institutions.
So that's what. So impeller assisted PCIs for elective plasties. For elective plasties, there are, as far as I know, in Mumbai, there is no one center in Mumbai which has an impeller console and catheter ready for it to go when there is a PAMI alert that comes in. That's not how impeller is marketed in our country. We
Fair
have
enough. I would reserve this discussion for the next day, where we will discuss about the impeller, and you would be the person who is going to teach us about it. So we will restrict that. Till then, I think if I would request Mehul to summarize, and if Dr. Pandit wants to say anything else. Otherwise, I will request Mehul to summarize.
No,
Sir,
I completely again endorse what Tala is saying. There is increasing amount of literature coming about offloading the heart, the LV, along with PTCA. So that's where the 5.0 impeller has been actually talked about more. And if we can do that, perhaps the outcomes will be different like other centers which we are talking about. Cardiogenic shock, the mortality is still very high in India. We don't have a very good outcome with cardiogenic shock yet.
So Dr. Mehul, if you can please summarize. Mehul being around, yeah.
Can you hear me?
Yes, now we can hear.
So I think this talk was very fruitful and it was a very well conducted session. Rohit has what do you call covered practically overall views about everything, and Tala added good important current updates. To summarize, one thing is take home messages I would definitely like to tell the audience is look at the ABCDE classification of the sky, which Dr. Tala did speak on. They're easily available on the net, and it's very easy for us to understand it, because you will be able to understand the risk and the type of patients that get into what type of mechanical circulatory device. So it just tells you about a classification, and then it tells you that the patient is going to be fit or not fit for the mechanical circulatory device. Mechanical circulatory devices are inherently made as either a bridge to treatment in the form of a heart transplant, either a bridge to destiny, because people probably may not be able to, get into or get themselves nominated for a transplant, or they are a bridge to, just an intervention which is likely planned. So, mechanical circulatory devices are something which are quite complex and difficult to understand. They can be understood when you are going to be able to do a hands-on to it and learn a little more about it uh, as you're seeing it in practical life. There are a lot of new devices like we spoke on, and there is a good amount of paradigm shift in the way that we are recently managing uh, cardiogenic shock. There's a lot of new devices, especially for the left heart and the right heart failure, which have been developed, which we must have small talks on, Arindam, in the future, so that we can take like the Impella or even the Protect Dio, which can give us an idea. Overall, the take home message is uh, you need to be able to identify these patients early. We need to be having a very lower threshold uh, with regards to invasive hemodynamic monitoring. I do find a lot of resistance towards invasive hemodynamic monitoring, going towards use of PA catheters and trying to use these catheters for cardiac output monitoring, using biochemical markers like lactates, and trying to understand that, look, we probably have a patient who at risk is now beginning to fall into a classical hypoperfusion syndrome, and that is not maintaining, and this is going into a state of deterioration before he gets into an extreme condition of landing up, coming to a point where we're doing everything at a last minute. It's important to identify these patients early and to categorize them and treat them appropriately. So I think this was basically the gist of the whole lecture.